There's a lot of odd people on cruise ships, odd passengers. Some people suffer from some sort of hero syndrome. The guts it takes for somebody to actually grab an ET tube and shove it into a patient's throat when you've only done it on mannequins. Hi, Tam here. When a medical emergency presents itself on a cruise ship, can you accept or should you accept help from passengers who are claiming to be emergency doctors? Let's explore that. So when a medical emergency occurs on board a cruise ship, it is crucial that the medical personnel be able to respond quickly and effectively. However, there's one thing that can slow down the response of the medical team to an emergency, and that is when passengers who claim to be emergency doctors and nurses offer their help and at times even jump in unsolicited into the action, and by doing so interfere with the protocols in place to respond to the emergency in the best possible way. So in fact, those passengers claiming to be emergency personnel on land end up interfering with the protocols in place on the cruise ship. Now, good Samaritans are and will always be appreciated. But while the offer is much appreciated, a good Samaritan must recognize his or her limitations, jurisdiction, scope of practice, and be able to step aside the minute the medical team arrives. The good Samaritan cannot impose himself or herself on the medical personnel. And I'm saying that because it's not uncommon when you have emergencies on cruise ships to see good Samaritans popping out of the woodwork and forcefully offering their help to the point where sometimes they have to be manhandled out of the action because they're just interfering and hindering with the best possible care that can be provided for the patient at that moment. And time and again, you will see good Samaritans imposing themselves on the medical personnel and encroaching on the medical response. And by doing so, disturbing the entire medical response. Now, the medical staff on a cruise ship is made of highly trained and experienced professionals. In an emergency or during an emergency, the medical doctors on board, the nurses on board, are all providing care in accordance with the AHA guidelines and ACS guidelines. From the AHA, your ACLS, your PALS. From the ACS, your ATLS. And yes, you are a passenger, you are a good Samaritan, you're eager to help, but you might be practicing, you might not have your AHA certifications in order, up to date, or perhaps your ATLS certification is not up to date. And so if something wrong happens, or unfortunately a negative outcome occurs to the patient, even though it wasn't your fault, if the family sues the cruise line, you will be left with a huge liability. Why did you provide help? Are you employed by the cruise line? Are you board certified? Okay, but where are you board certified? What are your credentials? Are your AHA certifications in order? You're telling us you're an emergency doctor, but is your ACLS up to date? Did you provide care according to the latest guidelines? Is your ATLS certification in order? Did the medical team specifically ask for your help? Why were you ventilating this patient at a rate of one breath every 2 seconds while he was intubated? And you said you might be liable, you might be exposing yourself to massive liabilities in court. But not only that, but the cruise ship doctors are also opening themselves for massive liabilities. Dr. Tam, you are the senior doctor on board. You are the head of department, yes? Why did you let this doctor help you? He mismanaged spine protection. We have him on camera manipulating the head while trying to secure the airways. And that led to the patient becoming quadriplegic. Oh no, but he told me that he was a board-certified emergency doctor with ATLS training and blah, 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 blah. And no, he's not hired by the cruise line. Now, I'll give you an example. One of a Good Samaritan's help gone terribly wrong. Now, some few years ago, I was the senior doctor on a cruise ship. It was around 8 o'clock at night on formal night, elegant night. And the nurse on duty got a call from the main dining room. A patient in his late 60s was suddenly unresponsive, unconscious, in the main dining room. I was not on call, I was not the doctor on call that night. My colleague, doctor number 2, was the doctor on call. So it's around 8 o'clock. The patient was eating his food, it's elegant night, became unresponsive. Immediately, the staff, the dining room personnel, the restaurant staff, call the emergency number. The emergency number goes to the nurse on call. So the nurse on call picked up the phone and she was told, please help, please come quickly, there is a medical emergency. You've got one of our passengers, one of our guests, who's unconscious, he doesn't seem to be breathing, he's not responsive, please come. And then the nurse, would have asked, so what's your location exactly? The main dining room. In the main dining room, deck 5 forward, starboard side. So the nurse on duty immediately picked up the emergency bag and proceeded to go to the main dining room. While on her way there, she called the doctor on duty to tell him, listen, I've just been called to the main dining room. I'm on my way there. There is a patient that's unresponsive. They're unable to tell me if he's got a pulse. They think he's not breathing. They're not sure. I'm on my way. Be on standby. If it's nothing too serious, I will then ask for the stretcher team to bring him to the medical center. But obviously, if it's a cardiac arrest or something serious like that, I call for an emergency response, which is the protocol usually, because the emergency response, when you call for an emergency response, that emergency response alert goes through the speaker system of the entire ship. It goes into all the crew cabins. It goes into all the areas of the ship, the restaurants, the public areas, the restaurants, the gyms, the spa, the nightclubs, the bars, look, some people are doing night shifts, some people are doing day shifts, so if you call for an emergency response and it turns out that, no, sorry, the guy was just intoxicated, he's not fully responsive, but he's gonna be all right. I'm bringing him to the medical center in a wheelchair. Sorry about that, it's not a life-threatening situation. If you do that at midnight, at 2 o'clock in the morning, the crew on board are not going to appreciate that. So that's the protocol we were following, which is good. So I was saying the nurses was going towards the main dining room, notified the doctor on duty to get ready, From the time she got called to the time she arrived, only 2 minutes had passed, When she arrived, she quickly assessed the patient and saw that the patient was not breathing, no pulse, CPR immediately, and then call for an emergency response. Now, the doctor on duty was himself not far away from the main dining room. He was literally less than a minute away from the main dining room at the time. So when the nurse called, he told her, I'm on my way as well, I'm not far from here. So they both arrived, so CPR is started by the nurse because she arrived first. The medical response alert is going through the ship. From the time the medical response is being announced, which is the first time I'm becoming aware that there is an emergency in the main dining room, to the time I got to the dining room with the rest of the team. And the team is scattered, right? So some are at the gym, some are having dinner, some are in their cabins, some might be in the medical center, I think at the time I was having dinner with the captain in the senior officers' mess. But anyway, I heard that and I rushed there. And it took me about 2 minutes to get there myself. And then within seconds, the entire medical team was there as well. As I arrived, the doctor on duty is there, he's doing CPR. The nurse is the opposite side of the doctor on duty, and there's 2 passengers there. One passenger is holding the head of the patient. The patient is already intubated and is giving bag mask ventilations. The other passenger is the wife of the gentleman who's taking care of the airway, and she's got a hand elevated and she's compressing a bag of crystalloids infusion. So I arrived there and I'm a bit surprised. Okay, why is this passenger taking care of the airway? So I asked, who are you? Who are you? And then she said, oh yeah, I'm a paramedic. I practice in Los Angeles, and this is my wife. She's an emergency. She's an ER nurse, and So we're there. We're at the table next door, and we arrived quickly. Actually, we saw everything that happened. Initially, we thought that the patient was choking, but it turns out that it's a cardiac arrest. But as a parenthesis, surprisingly, they thought it was a cardiac arrest, but they didn't start CPR. Our nurse started CPR when she arrived. But anyway, so things are ongoing there. So I'm the team leader, so I'm taking over. By the time I arrived, so the first shock had already been given, CPR for 2 minutes. I don't remember if the second shock was given when I arrived or I gave the second shock. That was some few years ago. But anyway, so we're doing the resus. Because the announcement went through, and the benefit of an announcement, of a medical response announcement, going through the entire ship, is that everybody comes, all the people that are assigned to come to such a response. So the stretcher team, which is a team of about 14 people, the stretcher team arrives. And those are the people who are going to carry the patient onto the stretcher, onto the gurney, wheel the patient to the medical center. Sometimes, the body might be in a very difficult situation, in an enclosed space. It can be difficult to retrieve the body, and the stretcher team is trained for all that. So the stretcher team is there, security arrives, chief security officer, assistant chief security officer, and then the other security officers, the staff captain, the hotel director, and who else? A lot of people, usually, even people who are not required to be there, usually, on that ship, they would just come. It was great, Everybody was helping everybody, no matter what the situation was. So I remember the housekeeping manager came as well, the food operation manager came, because it was in the main dining room, so you heard main dining room, so he came as well, and the maitre d' was there. Lots of people were there, the guest service manager was there, it's a big crowd. So anyway, we're doing the resus, patient is intubated, but now the paramedic is giving one breath every 2 seconds, whereby according to the American Heart Association ACLS guidelines, once you have a definitive airway, we give one breath every 6 seconds. So it's 2, 3, 4, 5, 6, 2, 3, 4, 5, 6. But he was doing, he was probably panicking. It was one every second, as I remember. So I told the guy, hey, you need to slow down the breaths. You're hyperventilating this patient. So he said, okay, no, I understand. And then he'd slow down, like 1 in 3 seconds. And then I tell him, no, please, slow down. 10 breaths a minute, 1 every 6 seconds, please. You're hyperventilating this patient. So I told the doctor, doctor number 2, my doctor, are you sure the tube is in the trachea? Are we ventilating the lungs here? Because it looks like you're ventilating the stomach, you know? So anyway, I wasn't convinced. So I'm putting my stethoscope on and I'm auscultating and I can hear air everywhere. So I'm hearing air entry in the right lung, in the left lung, and in the stomach too. So I'm not sure. I said, are you sure you went through the vocal cords? You're in the trachea here. So yeah, 100%. So anyway, I'm telling the paramedic now that, okay, you know what, thank you very much for your help. I'm going to take it from there. He's refusing to let go. He said, no, I got this. You know, so I said, no, but you don't know how to ventilate. You're hyperventilating this patient. Let me take over. No, but so the guy is actually refusing to let go to the point where I had to put my hand on his chest and physically push him aside and said, let me handle it. I'll take it from there. And I had to push him away, to shove him away from the patient. And so I took the tube, took the bag, ventilated once and felt like, no. I mean, just the resistance was all wrong, and there was a lot of regurg sounds and you know, fluid friction. So I told one of the nurses, give me a blade, let me have a look there. So they gave me a blade in the middle of a Mac. I look in there and there is secretions everywhere. It's impossible to see where the tube goes. We're in the main dining room. We've got limited equipment here. We've got manual suction. I'm trying to suction a little bit, but you know, it looks like the patient aspirated already massively before I even got there. So I'm asking, did this patient vomit? I said, no, he didn't. But you know, I mean, the guy was eating food and all that stuff, and he fell forward and possibly was choking a bit, so maybe there was a bit of regurg. And so I'm not happy about that. I don't want to remove the tube now in the dining room because I'm not sure if I take the tube out, I'm going to be able to see the vocal cords. And I don't want to second guess my doctor in a public setup like that. I trust my doctor, right? I mean, if he says he went through the vocal cords, he went through the vocal cords, he secured the tube, did an auscultation, confirmed with a confirmatory device, and everything's fine. And said, now let me look into the mouth. I look again with the blade, I suction, and I see clearly that the tube has not gone through the vocal cord. The tube is in the esophagus. So the paramedic was ventilating the stomach. And the reason why you could hear air in the lungs is because of refractory noises. After you ventilated aggressively 1 in 1 second for some time, and this patient was already a huge patient, obese. So it was not obvious to see abdominal distension because he had a massive abdomen anyway. So I'm looking there and I'm seeing the tube is in the esophagus, so I'm saying, oh shit, you know, the tube is in the esophagus. So I take a syringe there, I deflate the cuff, remove the tube, take another tube, push the tube in through the vocal cords this time, and then, you know, as we're ventilating now, it feels like we're in the lungs. There's good air entry in both lungs. There's still noise in the stomach, air entry in the stomach, because it's so distended before that air that, you know, the vibratory noises going from the lungs through the diaphragm into the stomach, you can still hear air echoing into the stomach. But clearly, there's better air entry in the lungs than in the stomach, plus also the tube going through the vocal cord, plus confirmation with EtCO2, capnography, I'm in the lungs. So now the doctor tells me that, look, I didn't tube this patient. He did. Points at the paramedic. I said, what do you mean? I said, no, he tubed. So I look at the paramedic and I said, did you intubate this patient? So yeah, you know, it's the first time that I'm doing an intubation in the stomach, actually. I've never done that in my life. I don't know what happened there, you know. Are you sure it was in the stomach? I said, my man, you know. So anyway, so we carry on there. I mean, epinephrine had been given, amiodarone had been given, 2 doses. We're back on epi now. and we could not achieve ROSC. So I'm telling the team, all right, we're moving to the medical center. Stretcher team, because you're on the floor. Stretcher team, we're taking the patient on the gurney and we're rushing to the medical center. So the stretcher team arrives, CPR is still going on. CPR is stopped for not more than 5 seconds. The patient is lifted onto the gurney. One of the nurses jumps on the patient's chest, on the gurney, and then CPR continues while we're rushing to the medical center. And we're there very fast, because when you go to the medical center, the protocol is that security will clear all the doors, all the elevators, everything is cleared. It's direct access to the medical center. So we're there in, I would say, probably 3 minutes. And while going there, CPR is ongoing, defibrillation is ongoing, drugs are being given, so nothing is interrupted. We arrive in the medical center. Mind you, as we're going there, the paramedic there, he still wants to be in the action, right? He doesn't get the message that he should let us carry on. So he's still coming with us there, he wants to go into the elevator with us. There's not enough space for everybody, so I tell security, take this guy away, please. The wife, she's still there, she wants to be involved, and we don't need the wife. We've got 2 doctors. We've got 3 nurses. We don't need them anymore. Anyway, we arrive in the medical center. They go into the medical center as well. So the stretcher team now takes this patient and then transfers the patient from the gurney to the ICU bed. And CPR is continuing and everything there. Now imagine the ICU room in the medical center is quite small. And you've got members of the stretcher team there. You've got 2 doctors there. You've got 3 nurses there. You've got a lot of people outside. And then this paramedic and his wife, they're also there in the ICU. So anyway, I'm telling them to please leave, and they're refusing to leave, and they're still hanging around. So anyway, after about 10 cycles, so 10 cycles, that's 2 minutes per cycles, 10 seconds interruption. So roughly about, between 20 to 25 minutes of CPR, the patient comes back. So I get a pulse back. So I'm checking for a pulse in between CPR, and the pulse is there. We get ROSC. ROSC means a return of spontaneous circulation. ROSC, ROSC. So we get ROSC, return of spontaneous circulation, meaning we can now stop the compressions. The heart is beating on its own, which is great. So now in ROSC mode, we now put the patient on a ventilator, with ventilatory settings and all that stuff. ROSC is actually the beginning, the real beginning of the care, because now there's so many things that you have to take care of. And ROSC, return of spontaneous circulation, means it's the time now, if you're in hospital, where you can transfer this patient to cardiac ICU via the cath lab. So usually, you're doing 20 minutes of resus in the ER. The cardiologist would be there with you. 20 minutes is a long time, so he would have been called and he'd be there as well. And then by the time you get ROSC, the patient can now be expedited to the cath lab and then to cardiac ICU, right? On a cruise ship, when you get ROSC, what we do is, okay, it's fantastic, the heart is beating again spontaneously, but we don't just clap hands and say, hey, well done, and leave the patient in ICU on ventilation and go to bed. No. It's the time, just like on land, it's the time where you have to look for the causes and the possible things that we can correct, because often the patient is going to go into cardiac arrest again. By the way, on 12-lead ECG, massive anterior MI. And at that point, because you can see now there's a massive MI, you need to thrombolize the patient. So you do your thrombolysis checklist. There's an entire list that you must check, And if there's no immediate contraindication to thrombolizing the patient, you thrombolize. And then, of course, you must look at the blood pressure. You must stabilize the blood pressure within certain parameters. You must make sure the patient is normal glycemic, meaning, you're achieving a normal blood sugar. That's very important because your patient is now in a coma and in ICU, ventilated. You want to make sure that is normal glycemic. You want tight glycemic control. Not too tight, but tight enough. What else? And then TTM, targeted temperature management. You want to make sure that your patient is at the optimal temperature for an optimal result, and to protect the brain and the heart. So because this patient was unconscious, the protocol, the American Heart Association protocol, is that the targeted temperature management range should be, if the patient is in a coma, between 32 to 36 degrees Celsius. All right. If the patient is awake, you don't need to worry about that. And it's 32 to 36 degrees for 24 hours and after 24 hours. But anyway, that's something else. So we're doing that, we're in the ROSC protocol now. And now I'm speaking to this paramedic and I'm asking him, can I see your credentials? So he says, I don't have my credentials with me. So in your wallet, you have a card maybe. So you're a paramedic practicing it. He said, no, I don't have my card with me actually. And so, okay, your phone, your practice number, your name, surname. No, I don't have that in my phone as well. It's in the room. So I said, okay, fine. Give me your name and surname. I just need to Google you, LinkedIn you, so that I can write your name and surname in my report because you arrived there before me and you were actually taking care of the airway and it seems you intubated the patient in the stomach. All right. He said, okay, yeah, okay, So I told, okay, and your wife as well. Please give me your credentials. Do you have your credentials? No, I don't have my, cell phone, nothing. It's in the room. Okay, thank you. So you guys both, please go in the room, get your credentials, and then come back. Check your emails and stuff. It must be there in your laptop or something on your phone. Okay, but anyway, I'm waiting for you. So they left. They never came back. In the meantime, I had to go to the bridge, speak to the captain, speak to the Coast Guard, organize a possible evacuation, a helivac so that the patient can go into cardiac ICU as soon as possible. It was another 2 days before getting the next port, so we couldn't keep the patient here. But the patient was, and then again I had to start thrombolizing the patient. There was a lot of work to do. So I forgot about these guys. The following morning, they had still not come back with their credentials. In the meantime, I had LinkedIn the guy because he gave me his name and surname, only to find that he's not any sort of paramedic. His name and surname and picture were there, but he was doing something that's got to do with allied health sciences. So I was really, 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 really upset there, And then I LinkedIn the wife as well, and on the wife there was nothing. Nothing. Every nurse is on LinkedIn, there was nothing. So anyway, so in the morning I called the room several times, no response. I made some announcement. I asked guest services to make announcements on the speaker system throughout the ship. Everyone knew, no response, because I thought maybe he's walking around, it's a sea day. It might be in one of the restaurants, it might be by the swimming pool, but anyway, no response. In the afternoon, still the guy had not come. So I had to ask security to actually bring him to the medical center. And then security brought him to the medical center around 3 o'clock when we opened the medical center. And then I asked him to bring me his credentials. And he said, okay, sorry, I forgot, and I'm coming back now. and he didn't pitch up. And finally I told the guy, listen, you cannot give me your credentials because you lied to us. You're not a paramedic in Los Angeles. You're not a paramedic anywhere. What you did was wrong. There will be medical legal ramifications for your actions. Who are you exactly? Then he told me, yeah, actually I'm involved with the profession, the health professions. I teach first aid. It turns out the guy was teaching first aid or training people in first aid at the mall or something like that, And then the wife was not an RN. She was not an emergency nurse. But she didn't do anything wrong. She was just holding that drip. So I would not blame her for anything. She didn't cause any harm to the patient. But she did lie by saying that she was an RN emergency nurse. And so this kind of scenarios, unfortunately, is not that uncommon. There's a lot of odd people on cruise ships, odd passengers. Some people suffer from some sort of hero syndrome. The guts it takes for somebody to actually grab an ET tube and shove it into a patient's throat when you've only done it on mannequins. And so yes, you see cases like that quite. Unfortunately, it happens more frequently than I'd like. You see people who come and they're telling you that, and they might be real doctors and nurses, but they want to interfere. And unfortunately, it happens quite a lot with people with fake credentials present themselves as doctor. And then you ask them, are you a doctor? Yes, I'm an emergency doctor. Oh, okay, so you're board certified emergency doctor? Well, actually, I'm not board certified, but I'm not exactly a doctor, but I'm a nurse actually, so sorry about that, Oh, so you're a registered nurse, an RN? Well, I'm not exactly a nurse, I'm almost a nurse. I'm actually, I'm not an RN, I'm a staff nurse. Oh, okay, so you're working as a nurse in a hospital, but just not as a registered nurse. Well, not really a nurse, not really a staff nurse. I'm actually I work at reception. Oh, so you're the receptionist in the ER in hospital. Well, I'm not exactly the receptionist. I'm doing hygiene management. What do you mean? I'm the janitor, actually. It's an extreme case, but you see my point. Never let passengers finesse you or convince you that the emergency doctors and then accept their help, because the liabilities will kill you and the passenger, notwithstanding the patient as well. As for the doctor number 2, obviously he was fired after that. Once the medical director was notified that he let a passenger intubate this patient, they fired him, Not a hard firing, but they let him finish his contract, and he was not rehired, And I think the problem here is that, the doctor, you're a doctor on a cruise ship, you're responding to an emergency. The patient needs to be intubated. For you to let a passenger intubate your patient, that's terrible. It doesn't matter if this passenger is the world's best anesthesiologist, and let's say he's got 200 years of experience. Let's say he's 240 years old, right? And he's been a doctor for 210 years. And he's been intubating every single day, 5 to 10 times a day for the last 200 years. And he comes in there, and you're in the main dining room, and he shows you some credentials there to say, hey, I'm Dr. So-and-so, I've seen on TV 200 years of experience, a million intubations, I'll take care of the intubation. No, you don't do that. This is your patient. Because when this guy tubes in the stomach and your patient dies and the case goes to court and it turns out that these 200 years of experience in hospital were not as an anesthesiologist, but were as a janitor, your head will roll. Hi, Tam here. If you like this type of content, please give me a like. If you want to leave a comment, please leave a comment. I will do my best to reply to you. If you know anyone that's interested in this type of content, recommend my channel to them. Don't forget to subscribe. My goal is to get to 500 subscribers by the end of the month.